Hello, I'm sat here with the most marvellous Carolyn Vandyken, who has graced me with a few moments before we run back into Essex, just to chat a little bit about her thoughts around a framework for a truly holistic biopsychosocial model in practice, which I think is hugely important, and that's something that we all need to be a bit more educated about. So, hello.
Oh, hello, Jilly. Well, thanks for chatting, and it's been so much fun to actually spend the weekend together. So.
Don't be jealous. But we
don't be jealous.
But we've had a lovely time and lots of wine. Just a little bit of wine, a small amount.
Yeah.
Now, I have just done Carolyn's online training, which is amazing and has vastly changed how I approach my framework to when I even start seeing patients and where I think I go. Because those of you that work with me know that I'm very psychosocial as well as the bio in my application, but it's certainly given me a framework for how to approach that. So did you want to talk a little bit about an overview?
Yeah, so I think one of the challenges that we have as physiotherapists is that we really are trained in the biomedical model, right? And our courses are biomedical, we live in the tissues, we look at mechanics, and those are great things. And I think when we take a biopsychosocial perspective, we should never forget that piece. We've had, I would say research has been knocking on our door for at least a decade to take a psychologically informed approach to our biomedical sort of processes. And that's been a really hard shift. It's been a really difficult shift for physios. And I get it because, again, we don't have a lot of extra training in the psychosocial bits and pieces. And so Sandy Hilton and I, about a decade ago.
Yeah, 2012, wasn't it?
The first one I think was 2010 and 2011.
Yeah.
So we had a chance to go to the Nottingham conference that David and Lorimer put on, and really walked away from that conference thinking, how do we integrate some of these really cool concepts of GMI, and you've done some really cool things with GMI, into clinical practice. And at that point, we had kind of decided that it was actually more about the framework that was missing. And I think that's true not only in pelvic health, but I think it's also true in orthopedics.
Absolutely. Orthopedic, MSK physios, this is for you as well.
Yeah, so
it's for everyone.
I think, it's been interesting. Certainly in Canada, I've spent the last 10 years developing pelvic health in Ontario predominantly. We had very few pelvic health therapists 10 years ago, like 5 in the province. And now we have 1,000, which is great. And so I spent a lot of my time in pelvic health, but you can't spend your time in pelvic health for too long without realizing that you really need to understand central sensitization and how that fits. And so really in this next decade, I really want to look at sort of pelvic health meets orthopedics, meets pain science. And we really need to all get out of our silos. So to do that, I think we need a framework. And so I teach this course that looks at, we call them SAD CLLIFSS.
Very SAD CLLIFSS.
They are SAD CLLIFSS. And so we look at actually, first of all, measuring sensitization. So using the CSI questionnaire, are they centrally sensitized? So now let's be really clear, we're talking about persistent pain. Right? So in acute pain, it makes a lot of sense to take a look at the bits and pieces that don't work. We have to remember that the body's incredibly smart and heals itself. So whenever we kind of think about the techniques that we're using is to help people heal, the body heals itself. We may facilitate it in different ways, but we also have to remember that by 3 months, everything that's healed is going to be healed, pretty much. So I'm going to borrow another Sandy Hilton-ism here for a moment and say that when we have persistent pain, it really is because things are tight, things are weak, or things are sensitized, right? So if they're sensitized, first of all, do we measure if they're sensitized, right? So the CSI is a great way to get an objective measure around sensitization.
And it's not just for pain. So one of the things that is really interesting is that you just apply this approach to everything. It's a lovely framework for how to go in with every patient, be it prolapse incontinence, be it shoulder patients. I still see MSK. So,
right.
The patients that's had, I can think of this week, that's had prolonged migraine since they were in their teens, and some endometriosis, and has come to see me with a shoulder-related issue and a back issue in pelvic health. And I CSI scored them, and they're really positive and massively catastrophizing and.
Right.
And that's where you will also start with this shoulder.
Yeah. So you know that this shoulder pain if there was no mechanism, if there wasn't a logical sort of mechanical piece to it, we have to stop trying to make things up or try to make things mechanical. I think often, and I did this for decades in my career, right? I just need to make them fit that box because I don't have another box to put them in. And so now we have, a la Lorimer and David and Joe Niche and a lot of great researchers. We have all this information on central sensitization, but I think when it comes to clinical practice, we then go, but where do I put it in? So some of us might do some pain education, and that's great. There's level 1 evidence in persistent pain that is helpful. But after I educate my patient, I can't then just go back and treat their tissues, right? We need to use a broader approach. So how do you do that? So this is the framework course that we put together, really looks at, first of all, are they sensitized? And if they are, what phenotype of sensitization do they have, right? And so we look at SAD CLLIFSS. I'm going to thank Anthony Lowe for that little mnemonic.
It's good.
Yes.
It's useful.
So SAD CLLIFSS, stress, anxiety, depression, right? Measured by the DAS-21. You would never assess a shoulder without disrobing the shoulder, going through all the range of motion, going through all the special testing. Why is it that we think we can treat sensitization without disrobing the psychosocial pieces?
Or even scoring it.
Exactly. So giving an objective measure, right? Yeah. Really looking at it carefully versus, okay, they're sensitized. Yeah, they have yellow flags. I think historically we have used yellow flags to blame the patient for not getting better or kind of get us off the hook for not getting them better. But what we need to do is we need to do a step better. So SAD CLLIFSS, stress, anxiety, depression, all significantly affect and sensitize the nervous system. If they're stressed, then perhaps they need, and we can teach them, practices that help to evoke the relaxation response. We can look at stress management. We can direct them to CBT, or we can incorporate some CBT into our clinical practice. Those are all evidence-based techniques that we can use for stress. Anxiety, if they're really anxious, maybe we really have to work on some grounding, really work on some breathing, really working on a worry journal, for example. Again, all strategies that we can use as physiotherapists to desensitize that distress and then get them moving. So stress, anxiety, depression. We then have catastrophization, right? We need to think about catastrophization from a persistent pain perspective. It's one of the strongest predictors of who will stay in a sensitized state if we don't deal with the catastrophization. Catastrophization is best dealt with pain education. Those are patients that really need to understand down to their toes that their nervous system is an alarm system.
And that it's a legitimate response. And that's what I like in all of this, is that whatever's coming out from the patient and whatever's being brought up is to them valid and legitimate.
Right.
And you always take the standpoint, even if we think that the patient comes in thinking, if I crack my knuckles, I'll get arthritis. We may think that's silly, but we're not going to say that that's silly, and we're not going to act or show in any way. We're going to work with them to really explore what that fear is. Yeah. And in pelvic health, we have masses of those.
Absolutely.
Huge amounts of them. So beautiful.
Yeah. So catastrophization, and then we've got low self-efficacy. So low self-efficacy, again, we could argue catastrophization, low self-efficacy, both strongly predictive of chronicity, probably equally so. And what does that mean? Low self-efficacy means that people don't have the confidence in their ability to cope and manage with what's ahead of them or what's going on with their pain. And so when people have low self-efficacy, I want you to start thinking, is this a patient I really should be doing manual therapy with? This isn't a patient I need to actively engage. I need to get them off the bed. I need to give them confidence, maybe put them in a group where they can watch other people being successful. So if we measure low self-efficacy, it's going to start to direct what I might do with that patient. That's the whole point of doing these distress questionnaires, is it actually helps to inform your treatment. It's not just an outcome measure. I think we have to kind of get away from, it's just an outcome measure and I'm collecting it for data. This is actually treatment planning.
What do I do?
Right, exactly.
Which is why I love it, because you have a string of questionnaires that you just give to the patient. It all comes back, and instead of where in my kind of trauma-informed and feeling my way with a patient, I might kind of feel they're more anxious about a topic and then go, well, we're going to do some exercise, we're going to do some of this, you're going to do some pelvic floor, whatever. and we're going to hone in on this and work with and massage this anxiety. Actually, I can then look at the questionnaire and go, oh, it's not anxiety. It's actually stress about that.
Right.
And then what you've got in the framework is a lovely table and lots and lots and lots of evidence about what is evidenced and within our scope that I can do, and when do I refer and who do I refer to, but what can we do how can we overlay our physio treatment with psychologically informed practices that are evidenced in that area, which I love because I love evidence.
Yeah. And not only that, just like you would take range of motion measures, if someone has a stiff shoulder, you're going to repeat these questionnaires, and the patients love them. One of the reasons I hear clinicians tell me all the time, oh, I don't give questionnaires to my patients because they don't like them. They don't want to fill out these questionnaires. Actually, when patients fill out these questionnaires, the comment generally is, wow, you did a really thorough job, and I really feel like you've understood my problem. Not only do we have a baseline, so what you measure, you can treat. If you don't measure it, you can't treat it. So if we're going to measure this or treat this stress, and we target it, in 4 to 6 weeks, we're going to remeasure their stress using the DAS to see if they're responding. And that's hugely motivating for them, and nice for you as well to say, yep, I'm hitting my target, or no, I'm not, and I need to reevaluate, maybe do something a bit different.
And from thinking about the most challenging of I hate saying heart sync because they're not heart sync patients, they're the most challenging persistent pain, because we're in it. I always feel like I'm in it with them. So they're in those challenges where you're just going, I can't even do graded exposure, we're getting nothing from this, I can't do imagery, where we might need to spend a lot more time doing this, but it gives you more options and more tools in your toolbox. And I can't remember her name, in South Africa, don't hate me, I forgot her name, but she says, my woo is evidenced, and this is the deep evidence in the communication skills that we have, and also how we can really bring the psychosocial into the biomedical model. But give it equal status. But also what I like as well when you do the central sensitization and say we know that a score of 40 or more is positive, we can use that with your patient to say, well, we know that you had some trauma from your recent surgery. We know that you have some stress and some fear around intimacy, and we can see that your CSI score is actually 79, so that's actually quite high. And now to me it feels like, or your CSI score is 90, as some of my patients. That feels like we've got quite a centralized element and less of it as a biological element. Is that how it feels to you? Would you agree with that? Or I did someone this week, I gave them all the measures, and they do love it. I think the reason that we say, oh, patients won't love it is actually because we have to do something with it afterwards. So you have to give yourself the time to go through all the measures. But I gave them to someone, and she came back, and she's a bladder pain patient who has had issues for 7 or 8 years. And it was very shocking, but her CSI score was 19. So really not significant. All of my ICSI, ICPI, the PI, so the problem index was really low. It was about 3, but the symptoms was high. So she's really not burdened and not centralised, but has these significant issues. And when we went through all of her scores, and I said to her, so we do this to check all of this, and she's there going, wow, no one's ever thought about this with me. And so I can kind of say, well, actually, we do need to look at the biological issues much more with you. Your depression, anxiety is absolutely fine. Your stress is moderate. It was something like 14.
Sure.
And
that means she's living.
Exactly. So biological, and actually there is less that I can do for you, but I think you need to see the consultant, and we need to look at gag layer replacements, and so it's a wonderful framework for understanding where we navigate our massive toolbox. But giving and I think to clinicians it gives strength and power to your communication and what you decide to do. Now in the UK we spent a lot of time talking about treatment outside the box, and that it's okay to put your pen down and listen, and all the human skills that we have, and this validates all of those. And
it validates and it objectifies it, I think, right? And so that's really important, right? So we've talked about stress, anxiety, depression, catastrophization, low self-efficacy. There's CLLIFSS, so then there's low positive affect, because we know that people who have a low positive affect have a compromised immune system. And pain is a neuroimmune response. So we want to know, and we can target low positive affect. We can target with gratitude training, with meditation, with exercise. Then we have injustice, and injustice is a big thing for a lot of people. This is God's fault, this is the world's fault, this is my fault. A lot of shame maybe in that whole piece, and so injustice. It's hard to actually not be sensitized when we're beating ourselves up all the time, right? Or beating someone else up all the time. Fear. We cannot talk about psychosocial without talking about fear, and I would defer to Peter O'Sullivan's work and a lot of the great cognitive functional therapy kind of approaches that he's working on for that. And then we can talk about shame, right? And shame is harder to measure, so we don't necessarily have a great objective measure, although we have some measures that look at self-compassion. And self-compassion and shame cannot live together. So if someone has a really low self-compassion score, then shame is probably part of that story, right? And so and again, in our patients in pelvic health, shame can be such an important piece of it. I don't like my body. If they've gone through trauma, it was my fault, I was responsible, all of those sorts of things, right? Guilt is I did something bad, shame is I am bad, and it's that shame piece that we really, in a lot of our patients, we're not necessarily picking up or identifying. And then we have a cliffhanger with SAD CLLIFSS, because the course really goes over all of those different parameters, and then leaves smudging. Smudging is the last S on SAD CLLIFSS. And smudging is another course unto itself. And smudging is all about using the Fremantle questionnaire, which Ben Wand and his group have validated, looking at sensory motor changes in persistent pain and how our exercise needs to look different, how our exercises need to be more novel, neurocentric, really aimed at calming the nervous system down or clarifying those maps. And so that gets to be another whole sort of one-day course on its own. You haven't done that one yet?
Nope.
In the near future, that would be great.
Absolutely, absolutely. But I can't thank you enough, because it was it brought together so many things that we are thinking about, and certainly from an evidence point of view, and it slots so nicely into practice. Be it you're treating post-hip replacements all the way through to anything else, because as long as you've got that kind of framework in your mind of it takes away the stress and the fear of, how do I approach this patient, this really, persistently, low back pain? How do where can I go? They're not compliant.
Right.
They're, all these questions we have. Oh, they won't do their exercises. Well, why? Right. What is it in their psychological and social framework, which is where they have the issue? And if it isn't anything, fine. But if you can always pick up on stuff and refer them to your clinicians locally. Right. So there's psychological services. Or if you feel like it's not too much of a big thing, then you can try and do some stuff yourself and see if that makes a difference. Yeah. But I found already it's giving a strategy to my treatment that is so much more effective. Awesome. Immediately.
Awesome.
So thank you.
Well, I have to finish maybe with one quote from Professor Eccleston from IASP 2018 last year, where he said in his keynote address that he won from the Ron Melzack Award, the highest award you can get in IASP, and he said the time has come where all clinicians, if you're a medical clinician, whether you're a doctor or a physiotherapist that treats the body, we need to integrate psychosocial into every one of our clinical interactions. And if you're a mental health worker and do more psychosocial stuff, you need to integrate the body into your work. We can no longer, in persistent pain, be divergent in that. So yes, it's great to refer out, and I refer out to psychology all the time. I'm not trying to be a psychologist, but there's lots that we can do as physiotherapists within our clinical practice that is psychologically informed and really helpful. Remembering that people aren't mentally fragile, they often are their own best counselors, nor are they physically fragile, right? And we need to remember those two things. So thank you.
Thank you very much.
You're welcome.
And I will put links to Carolyn and how to get hold of her and her clinic and stuff like that underneath this. But yeah, if you get the opportunity to go on her online active live courses, then do it. Thank you.
Thanks, Julie.